Is it necessary to fast prior to do a thyroid function test, especially if people are on medication? And do they do it before the medication, taking the medication? That's a very pertinent question.
Yeah. Um, ag- so in people that are on chronic levothyroxine therapy, it's important to measure thyroid function tests at least once a year, just to make sure that the dose is appropriate and that in fact, that they are compliant with their medicine and they're taking it every day. But the time of day and the relationship of taking the blood test in relation to taking their medicine really isn't that important. The levels really don't change whether you take the blood in the afternoon or the morning before they took their dose. Because remember, the half-life of the dose of the drug is 7 days, and the TSH levels really don't change from day to day. So no, it would be, for the patient's convenience, it just doesn't matter. They can take their pill and have their blood test or not take their pill. Doesn't matter. The main thing is to have the blood test. And I would recommend doing it at least once a year.
And any opinion, especially those who are being monitored by free T4 like secondary hypothyroidism, do they require to take it before the medication or after? Any
I don't
interference?
think no, I mean, the T4 levels may change by 10% or something like that before or after you take the medicine, but it doesn't really matter. One thing I would say is that, and I am guilty of this myself. When I have a patient with hypothyroidism, obviously it's the TSH you want to check, but I can't resist checking their free T4. I mean, I don't want to check the box off, but my hand just goes to the box and I check it off. But the reality is you really don't need to check the free T4 in people on chronic levothyroxine therapy. It's really the TSH.
With regards to treatment, especially with GLP-1, which we are frequently using nowadays in diabetes. So, do we need to have that gap now? What they have recommended is with regards to thyroid hormone because of interference, especially with the medication and GLP-1, the oral GLP-1, especially like semaglutide.
Uh, I'm not aware of any interactions between these drugs and levothyroxine absorption, and certainly the patients and physicians are contacting me at least 2 or 3 times a week about the potential effect of these drugs to cause thyroid cancer or thyroid nodules. And again, just to emphasize, there's just no evidence that these drugs cause thyroid cancer in people. It's only in animals. And the animal cancer they get is medullary thyroid cancer, which is a very, very rare cancer in humans. So there's no reason to even think about the thyroid in terms of starting one of these drugs, unless there's a family history of medullary thyroid cancer, which, is very, very rare.
Any special, precautions, especially with regards to some of the patients taking lithium, which is
Well, yeah, lithium can cause hypothyroidism. So it may be that the person's hypothyroidism is caused by the fact they're taking lithium, but other than that, no.
and do you recommend the absorption test, the levothyroxine absorption test in any of the patients?
Well, there are some very challenging patients who maintain that they are taking their medicine faithfully each and every day, and yet when they come to see you, their TSH is 50. And why would this be? So yes, there is a T4 absorption test where the person comes in, takes 1,000 micrograms of levothyroxine, and then has their free T4 measured hourly for 5 hours. And in my experience, 99% of those people absorb the medicine just fine. And so they're just not taking the medicine or they're not taking it correctly. But if a person has absorption problems, let's say a person with atrophic gastritis, a person on a proton pump inhibitor, liquid levothyroxine also is available, and that does work because you don't need acid in your stomach to absorb it. And so that would be an alternative for people who have gastric atrophy or some other malabsorption issue.
And especially in patients who have cognitive impairment with subclinical hypothyroidism, even TPO negative, do you think trial of thyroid hormone is justified?
I really do not. I mean, it's hard to resist trying it. And, if the family wants to try it, and it's pretty harmless, if you're monitoring and make sure you don't overtreat the person. But I don't think there's any evidence that it's going to help a person with cognitive impairment,
And
unfortunately.
and also with regards to obesity, a lot of patients with subclinical obesity, actually normalizing the weight may be helpful. Do we go for treatment in those? Any benefit in
No,
subclinical?
I didn't have a time to mention this, but in people that are markedly obese with, let's say, BMI greater than 40 or 45, that in and of itself causes a high TSH level. And it's not due to a thyroid problem. It's actually due to leptin, which is circulating from the fat. It's produced by fat cells and actually has effects on the hypothalamic pituitary axis to stimulate the secretion of TRH and then TSH. And after, uh, let's say, weight reduction therapy or weight reduction, the TSH goes back down to normal. So some people with massive obesity just have a high TSH, but it's not due to a thyroid problem.
And especially patients like who have any supraventricular arrhythmias, having hypothyroidism, because that's a tricky situation, especially having overt hypothyroidism, and on top of that having supraventricular tachyarrhythmias. We get them especially in the elderly population sometimes.
Yes.
So
Yes.
starting treatment maybe even a little bit, or especially adjustment of treatment. Any special advice would you have?
It's just the start low and go slow theory. I mean, the way I think about it though is that it's possible that maybe some cardiac abnormality might be improved by normalization of thyroid function. Maybe being hypothyroid has effects on vascular system or lipids that is actually making their cardiac problem worse. So maybe treating them might actually improve things if you do it judiciously.
Thank you for a wonderful interaction from our side.
Okay, thank you so much for your attention. I really appreciate it.
Hello. Thank you very much, Dr. Cooper.
Thank you.
There are, it was a wonderful talk, and you clarified many of our doubts. Still, there are some questions.
Sure.
In India, we have multiple brands of thyroxine available.
Mhm.
So, a patient is on a particular brand, and if the brand is changed after 6 months or next visit, or frequently if the brands are changed, will it make a difference?
Well, that's an excellent question. And we have the same situation here in the US. There are a dozen different companies that make levothyroxine. And when you prescribe levothyroxine to a patient and they go to the drugstore, they easily could be switched from company A to company B. And although you might think that there should be no difference between the two companies, we just don't know for sure. Now, in the US, we have generic drug laws that require generic drug companies to prove that their product is the same as the brand name product in terms of its absorption and profile of T4 levels in the blood after you take a dose of medicine. But you can't be sure. So what I recommend is to the patient is that if you go to the drugstore and you're given something, the patient has no control over this in the US. They just go to the drugstore and get a product. And if it looks different, the pill is a different shape or a different color, then we should probably recheck their TSH in 6 weeks. But most of the time, it's pretty normal and it's not as big an issue as you might think, at least in our country. But I would
Okay.
recommend if that happens to a patient, they should have their TSH rechecked in 6 weeks.
Yeah. And another question. Many of our patients are on proton pump inhibitors.
Mhm.
So we know that thyroxine absorption requires gastric acid. So do you think it matters if somebody is
Well,
on
yes,
proton pump inhibitors?
yeah, it matters. In many patients, when they get started on one of these drugs, their TSH goes up because it interferes with the absorption of the levothyroxine. But this can be overcome by increasing the dose, usually. So if a person is started on one of these drugs and their TSH goes from 2 to 17, then you should increase the dose. And if you still are unable to normalize thyroid function, which doesn't happen very often, but if it does, this is where the liquid levothyroxine preparations come into play because they don't require acid to be absorbed. And I think you have those in India also, if I'm not mistaken.
No, we don't have liquid preparations.
You don't. Okay. Well, this would be a role in US for you a liquid, but I think in most cases the absorption problem can be overcome by increasing the dose.
Okay, thank you. And what about replacement in patients who have undergone bariatric surgery? Do they require larger doses?
Well, one of the interesting things about massive obesity is that the TSH level can be increased due to the fact that they're obese. So obesity itself leads to increased levels of leptin in the circulation, and leptin stimulates the hypothalamus and pituitary to make TRH and TSH. And as soon as the person loses weight, their TSH goes down. So many people that are obese masquerade as having hypothyroidism when in fact it's obesely related high TSH levels. But
I'm
if you're,
asking after bariatric surgery.
yeah, oh, because of malabsorption, you mean?
Yeah.
Oh, yeah. I mean, sometimes that is the case, that the dose has to be changed or increased or even decreased because now they weigh less than they did. So they have to be retitrated after the surgery. Yeah.
Another question is in patients with chronic kidney disease, do we need to monitor just like in another patient of hypothyroid, like monitoring only TSH, or do we need to monitor T4, T3, and what care should be taken while treating patients with CKD and hypothyroidism?
I'm not aware there's any effect of CKD on thyroid metabolism. So you don't need to do anything differently.
Okay. And somebody has asked, what is the upper limit of thyroxine dose you have ever used?
Oh, maybe 400 or 500 micrograms a day.
Okay. And another question is, if somebody is on levothyroxine replacement and T3 and T4 are in mid-normal range, while TSH is zero point zero 0.01 or TSH is clearly suppressed.
Mhm.
So in that situation, what should be done?
Well, the usual, teaching among endocrinologists is it's the TSH that dictates the dose of medicine, not the T4 or T3. So in that case, I would decrease the dose of levothyroxine in an attempt to normalize the TSH. Now, another possibility in a case like that would be that they actually have central hypothyroidism and that their TSH is low because they have a pituitary problem. And so in that case, then you would just want the free T4 to be in the mid-normal range because the TSH cannot be used to monitor them.
Yeah.
You just monitor the free T4.
Okay. And one more question. Patients who are undergoing surgery, major surgeries like coronary bypass or knee replacement surgeries. So before surgery, is it necessary to normalize their thyroid functions, or they can be taken with overt hypothyroidism for surgery?
Well, it just depends on how emergent or crucial the surgery is. I think optimally, you would want the person to have normal thyroid function before they had major surgery because it could interfere with the metabolism, let's say, of the anesthesia. They may have abnormal circulatory function. Um, but if it's, let's say the person has a TSH of 20 and they need urgent bypass surgery, I mean, you just do the surgery. I think that it just depends on the clinical situation. If it's elective surgery, they should be normal before they have surgery. If it's more emergent, then I think they don't really need to be titrated up, and the surgery should be done. There's really
Thank
not
you.
a lot of
Thank you.
evidence. There's not a lot of evidence that being mildly or even moderately hypothyroid has any effect on the surgical outcomes.
Okay. Thank you very much.
Okay, you're welcome.
Thank you.
Thank you.